MERS, Middle East Respiratory Syndrome, to avian influenza, Nipah virus, and most recently COVID-19. The majority of cross-border outbreaks with pandemic potential have been viral in origin, underscoring the growing intersection between human health, animal health, and the environment. Today's discussion is inspired by global reflections on what has been described as the double whammy of zoonotic diseases, where communities face not only infectious risk, but also economic, agricultural, and food security consequences when outbreaks emerge. My name is Sabiha Isaac. I hold a Saatchi chair in antimicrobial resistance and One Health, and I've been working in AMR for the past 32 years. I share the platform today with three preeminent panelists from the University of KwaZulu-Natal, and it is my pleasure to introduce them to you very briefly. Our first panelist is Professor Yunus Musa, who is Chief Specialist and Head of UKZN Department of Infectious Diseases. He obtained his undergraduate and postgraduate degrees at the University of Natal and obtained his PhD in immunology and microbiology at Wayne State University in the US. His work focuses on the care of inpatients and outpatients with complex infectious diseases. He is involved in clinical training at undergraduate and postgraduate levels in the province of KZN. His research interests include immune reconstitution, inflammatory syndrome, smear-negative tuberculosis, and antiretroviral resistance. Our next panelist is Dr. Nakukanya Okanya Msomi, who is the UKZN NHLS head of the discipline of virology, leading the Nkosi Albert Luthuli Academic and Diagnostic Virology Laboratory, which services the entire province of KwaZulu-Natal. As an earlier career researcher, Dr. Msomi received doctoral research funding from the NRF and a scholarship from the Wellcome Trust to study viral genomics and bioinformatics at the Sanger Institute in Cambridge in the UK. Her area of research is in the pathology of viral hepatitis, which formed the basis of master's and doctoral research. In 2025, she received a C2 NRF rating as an established researcher. Dr. Msomi is currently on the board of trustees of the South African National AIDS Council, and she has also served 2 terms as a member of the National Polio Committee, driving the country's efforts in polio eradication in collaboration with the WHO. And our final panelist is Dr. Ngobile Pakati, who is the facility manager of the Biomedical Resource Unit and a veterinarian. She holds a Bachelor of Veterinary Sciences and a Bachelor of Veterinary Biology from the University of Pretoria, along with the highest certificate in business management from Regent Business School. She completed a laboratory animal science course at the University of Cape Town, and as head of the BRU, she is responsible for overseeing the laboratory animal research, managing business operations, and ensuring the health of animals. Prior to this, she worked as a poultry veterinarian and product manager at SIVA Animal Health and as a state veterinarian in Mpumalanga Department of Agriculture, where she focused on disease control and clinical services. So as you can see, we have a very eminent group of people who are going to share their insights. So let me begin by setting the scene on decades of zoonotic spillovers. Since the 1980s, over 60% of emerging infectious diseases have been zoonotic. Many have originated in settings where wildlife, livestock, human interfaces are intensifying. As a result of agricultural expansion and deforestation that alter ecosystems, informal markets and food systems that increase exposure, and then finally climate variability that shifts vector and host distribution. As highlighted in recent global analyses, zoonotic outbreaks create a double whammy. They threaten public health while simultaneously undermining livelihoods, livestock production, and rural economies. So let's begin with a question to Dr. Madlalose. From a virological perspective, what makes viruses particularly prone to cross-species spillover and rapid international spread, please?
Thank you, Professor Isaac, for that kind introduction, and good day to all colleagues and everyone joining this webinar. As you have very well said in your introduction, there's a very delicate interplay between pathogens, which include viruses, the environment, as well as the host, be it animal or human being, in viruses emerging or pathogens emerging. From a virological standpoint, viruses evolve in such a way that they gain an ability to infect different types of species. This is further enhanced when there is encroachment into areas where animals live, allowing the viruses to have proximity between humans and the animals where they originate. And that enhances or favors the spread of viral infections from the animals to human hosts. But the main driver is the ability of viruses to evolve through mutations in such a way that they gain an ability to either overcome control measures that exist or to bypass effect that is offered by treatment and vaccines. In a nutshell, that would be the viral driver of emergence of infections. Thanks.
Thank you very much for that introduction and giving us a perspective of viruses in particular. Professor Musa, you're a specialist in infectious diseases. Would you give us the clinician's perspective of outbreaks and zoonotic spillover, please? I believe you have a slide presentation to share.
Yeah, so let me share the slides and I'll talk you all through that. Okay, so essentially one of the tricky things about a clinician is that they need to realize that there's an outbreak, and they usually do that while they are in their practice of medicine. And for you to be able to note that there is an outbreak, you need to be very vigilant about the kind of patients you are seeing on a daily basis, because the challenge is you need to see something atypical. Now, not everyone is vigilant all the time. So there are certain situations in which you want somebody to be on the outlook for an outbreak, because the risk of an outbreak is very high. And the situations are when you have a breakdown in water, sanitation, and hygiene, because you can imagine that would become a source of infection. As Sabia has mentioned, the climate change increases the risk of infections because of change in weather patterns, heat and flooding. Then you need to be vigilant about an animal-to-person transmission, usually in areas where there is close interaction between humans and animals, like deforestation, villages that are close to the forest. That's where you have animal and human interaction. The unique thing about China is that the human-animal interaction is much more intimate, because the Chinese, the way they live their lives, their animals actually live with them in their quarters. So there's a lot of animal-human interaction. When you have breakdown in healthcare services like failure of immunization, then you worry about the possibility of an outbreak. And most importantly now, you can see international travel has made the world into a very small place. So an outbreak elsewhere doesn't exempt you from trouble in your area. So you need to be vigilant for that. The important thing to remember in your practice is to look for something atypical. Is somebody presenting in an atypical manner? Are the number of people that are presenting more than what you would usually expect? Are there increased emergency room visits? Are there more hotline calls about somebody who's not well? Absenteeism from school? All of these are flags that there are large proportions of people who are getting sick. Also, what's important is social media. You know, people, when they get sick and they find that it's happening more frequently, they would post on their social media. So that's also an important area to be vigilant for. And then you need to remember that sick animals can also be a flag. In the US, when they had the Nile virus, they found dead birds was a signal that the Nile virus was around. And then finally, the laboratory is also an important area for vigilance, because they would pick up certain organisms in samples that are coming up that would show up a particular virus that's more commonly been found, or a particular bacteria that is more frequently being found. So the question then arises that who should you suspect is involved in the outbreak? That is important, because the people that are involved in the outbreak might give you some hint about the organisms that you are dealing with. Is it children, the elderly, the immunocompromised, or people who are traveling? Is it in a particular area, geographical area? Is it possible to pinpoint the source? If people know the history of cholera, it was because of case mapping, spatial mapping. They figured out that the outbreak was coming from a particular water pump, and that was pinpointing the source of the infection. And then finally, you need to remember about active case finding versus passive case finding. If a traveler has come down into a country and is suddenly diagnosed very early on with an infectious disease infection, then you need to be concerned about all the people he was exposed to on the plane and during his travel, that you need to go and actively find them rather than passive, as we did with COVID. So all of these matter when it comes to a clinician considering that there might be an outbreak. What is important when you're thinking about an outbreak is establishing a case definition. And a case definition is a way of determining if an individual's risk for having had the infection is particularly high. So you look at the symptoms. For example, when it came to mpox, we talked about the vesicular rash and the kind of exposure the individuals have had. When you're looking at COVID, it is essentially exposure to somebody who's had a flu-like illness. And all the fever we talked about, the rashes we talked about, the loss of taste you might remember we talked about. And then you look at characteristics of the population that are involved. That will also feed into your case definition. If it is mainly travelers, then that becomes an important aspect of the case definition. That's what you did with COVID. People had to have had a travel history. But once it started spreading within the community, travel history became less relevant. Also, geographic locations where the outbreaks have happened would matter. Is it in a school setting, nursing home, barracks? The timing of illness is also very important because you need to think about incubation periods. How long between the exposure and the illness? That's important in terms of using the case definition to decide if the person has been exposed, are they at risk for an illness? And then finally, laboratory tests that can speak to the infection. Also, an important part is infection prevention control. The whole idea of detecting that there is a possible outbreak is a way of containing the outbreak. And how do you do that? Noting what kind of infectious agent you are dealing with is important, whether it's a virus, bacteria, fungus, or a parasite. How does the organism get into the individual? How does it spread from an individual to individual? How long is the incubation period? So you know that if somebody has been exposed, if they're still within the incubation period, then they might turn out to have the disease. If they've gone beyond the incubation period, despite the exposure, then they're unlikely to have got infected. And then how infectious the organism, the individual is. And that is determined by looking at the basic reproduction rate, which is the average number of new infections that can be caused by one infectious person in a completely susceptible population. And finally, the duration of infectiousness also matters. Is the person infectious before they become sick? Because you can remember containing an outbreak becomes very difficult if the person is asymptomatic and is transmitting the virus. Are they infectious after the infection? So that will tell you how long you need to isolate the individual. So these are all factors that need to be taken into account. Then you want to know how stable the organisms are in the environment. How do you disinfect the environment? How resistant are the organisms to the disinfectants? And how fatal the disease is? If you've got a low fatality outbreak, then the stress and the pressure to find people, isolate them, and protect them is less than if you have a disease with a high degree of fatalities. And then finally, antimicrobial resistance also becomes an issue because often when doctors see infections, they use antibiotics, often unnecessarily, and that can drive resistance. So those were the few slides that I put together, hopefully to generate discussion. Thank you, Sabir.
Thank you very much, Professor Musa. That was indeed interesting, and I will pick up on the antimicrobial resistance aspect of it a little while later. Our next question then is for Dr. Obile Pakati. I wanted to look at the structural drivers. So the rural and agricultural dimensions of zoonotic outbreaks are often underemphasized. How do livestock systems, food security, and informal economies amplify this vulnerability? Over to you, Ndobile.
Thank you, Prof, and good afternoon, everyone. So when we look at livestock systems, these can be broadly categorized into two groups. So we have your commercial operations, which are mainly intensive. And what that means is that you have a high number of animals within a confined space, right? And normally the biosecurity measures in these operations are quite strict. And so, but in the unfortunate event of an introduction to a pathogen,
that can be quite detrimental, as it can spread quite rapidly in a short space of time, affecting most, if not all, the animals involved in that operation. And a perfect example of this would be our avian influenza outbreak that we had in the poultry industry recently. Then the second group of livestock systems that we have is your backyard or small and rural, smallholder rural operations. Unfortunately, with most of these operations, the biosecurity measures are often limited. And it's important to note that these limitations are not due to negligence of the farmer, but rather just due to limited resources, limited infrastructure, and limited exposure to veterinary services. And now all these limitations then drive to limited reporting, limited diagnostics, and inconsistent detection, which then leads to the pathogens silently circulating in the environment for a while before actually being identified. So when we look at countries like South Africa, it's important to note that livestock systems are more than just production units. They're actually people's livelihood. They are school fees, they're people's daily source of protein, and ultimately they are the economic drivers of those families. So when reporting a disease, when a farmer has to report a disease and they are told that they must cull out all their animals or kill all their animals without adequate compensation, it becomes quite tricky because now he must choose between public health and the survivability of his family. So now such tensions then drive underreporting, or worse, the sale of sick animals just to try and recover costs. And you can imagine that will then drive or increase transmission, not only to other animals, but also to humans as well. So when we discuss preparedness in the pandemic treaty era, we need to recognize that the spillover is not only a biological event, it's a systems event that reflects where animal health systems, food security pressures, and informal economies intersect, right? So when we're shaping preparedness frameworks, we cannot just focus on urban hospitals and lab networks. As that can lead to a risk of overlooking the agricultural front lines, which serve as a source of many of these zoonotic threats. So we need to ensure that building resilience in the animal health systems is recognized as a fundamental part of preparation rather than just an option. And these are the fundamental ways in which we can build resilience in the animal health systems. We can strengthen veterinary services. We can invest in rural surveillance, improve compensation mechanisms for farmers, and also integrate One Health strategies into agricultural extension services. So for me, in closing, in the pandemic treaty era, recognizing that animal health systems, food systems, and trade systems are not just peripheral to health security, but they're actually central to it. Thank you.
Thank you very much for that wonderful public health perspective and the importance of ensuring that all kinds of food production systems are incorporated, and that preparedness is not restricted to one sector alone, but is actually a One Health approach. Both you picked up on the biosecurity aspect, and Professor Musa spoke about antimicrobial resistance. So I have to make a mention of that. So when it comes to any kind of infection, the first go-to for any clinician is an antibiotic. In the case of COVID, for example, we hadn't looked into the etiology. We were sort of building the train or building the tracks while the train was going. And so the go-to was antibiotic treatment, especially in the hospital setting. When we speak about biosecurity, it is expensive, as you quite rightly said. And so we resort to using antibiotics in the feed and food of the animals that we are rearing. And all of this use then causes selection pressure for the evolution of resistance and compromises treatment in the future with other diseases as well. So antimicrobial resistance plays quite an important part in all kinds of disease, but also specifically in zoonotic spillovers. So we've spoken about zoonotic spillover and the human-animal environment interface, whether the animal is wildlife or food animals. But I want to now move a little bit to the actual pandemic agreement. In 2025, last year, all WHO member states adopted the WHO pandemic agreement, recognizing that prevention, preparedness, and response require legally grounded global cooperation. So we didn't want to ever have to go through something like COVID again. And so they worked on the pandemic agreement, which after many iterations was finally approved or accepted in 2025. Now, this agreement emphasized early warning and pathogen surveillance. It speaks about equity in access to diagnostics, vaccines, and therapeutics. So remember that not all countries equally had access to the tests or the vaccines when they became available. It speaks about data sharing, a strong One Health approach. So given that most cross-border outbreaks in the recent years have been viral and zoonotic, this framework, this pandemic agreement is really very, very relevant. So maybe I will start with one question and anybody in the panel may answer, but may I please also encourage the audience to stick their questions into the chat, and I will take them after we have this next set of questions. So the first question related to the pandemic treatment is, what practical steps must countries take to operationalize One Health beyond the rhetoric? So we all speak about One Health. AMR is a quintessential One Health issue. Climate change is a One Health issue. Pandemics are a One Health issue. But how do we operationalize One Health? Who would like to go first?
May I ask an additional question? So essentially, we are, from what I'm gauging from what you are saying, is that it's not just about the humans. It's about taking care of the animals as well. And if we take proper care of the animals, then we hopefully will prevent this from spilling over into humans. Am I getting that correctly?
Yes, absolutely.
I'm guessing that vigilance amongst the animals might be probably the first and primary way to be monitoring for these infections. Would I be correct, Nobile?
Yes, you're very correct, Prof. But remember, one of the limitations that I mentioned was that a lot of these rural operations do not have exposure to veterinary services. They might now and then encounter an agricultural extension officer, but normally those officers are not trained on One Health education. So that's why one of the key or fundamental ways we can actually build resilience is to now integrate One Health into those agricultural extension officers, so that when they are on the ground, they then start the conversation of zoonosis, start the conversation of you need to report if you see something off. So it's important to just get to integrate the One Health concept into the agricultural extensions.
If I may
Sure.
come in as well.
Yes, of course, of course.
Thank you. So I think what the pandemic treaty is all the lovely things that it's trying to address. The key messages or things that can operationalize it is strengthening our systems for surveillance across the board. A lot of our surveillance is passive. If there can be a strengthening of active surveillance from in the routine programs, so that there is early detection and early warning signs, where we can track signals where something is, perhaps a pathogen is being picked up more than it is expected for a particular time and place. Another area it's trying to address, which was not a good experience during the COVID time, is the equity and the equitability of resources to respond when something happens. And I think countries can implement or operationalize by strengthening manufacturing abilities. The most important thing is not just to have access to these fancy diagnostic assays or treatment that we use, but to have the ability to continue to manufacture and supply our own demands even when the borders are closed, because that usually is a response when there is an outbreak of public health significance that threatens the world. People close their borders. So that could be another way of strengthening our ability to respond through strengthening our own manufacturing ability, as well as producing our own preventive and control measures. And so it's not just research part of it, but operationalizing that and implementing it to use so that it becomes useful when the need arises. Thanks.
Thank you very much. The importance of equity and equitable. Yes, please go ahead, Professor Musa.
Yeah, so surveillance is easily said than done. The problem is that you've got over, I'm guessing, 40, 50,000 practitioners in the country, you know, and everyone is working in their own little silos. And you can have an outbreak where you've got maybe 20, 30 patients and they're all going to different practitioners. Nobody ties it up together. So I'm just thinking that one of a common hub are often the labs. So do you see the labs playing a particularly important role in surveillance? And remember, we only find what we look for. And often these pandemics are caused by organisms that we don't know have come across. So the next question is that how do we find out what is responsible? So those are the kind of questions that are going through my mind. So Kanye, what do you think about the labs? Is there a system amongst the virology labs to be speaking to each other or something like that?
Absolutely. Fortunately, the country uses the same laboratory network, so and there are systems for mining the routinely collected data to pick up signals when something is a red flag. So yes, that does happen. But like you said, a lot of outbreaks that are novel, like in the case in point of COVID, it would be something that we're not routinely looking for. So in addition to that, it will also creating an ability in the lab systems for also implementing what we call catch-all diagnostic assays that find things, you know, when you get a negative result in a sick patient, that should be cause for concern and increase the index of suspicion to look for something we don't ordinarily look for. And yes, that does happen, but it could be happening in a more organized way and more routinely.
And so one other challenge.
Sorry,
Sure.
Professor Musa, I'm the moderator.
No, I was just going to ask your permission if I could say something further.
Sure.
You see, one of the challenges we have as clinicians is that we go by clinical signs and symptoms. And one of the problems with infections is that they actually present in very similar ways. Now, if you look at Mpox, the good thing about it is it had something unique. It had those skin rashes that immediately portray it as something weird and wonderful. But if you look at the COVID, for example, it presented like an upper respiratory tract infection. And where the penny dropped is in the frequency of the cases. You suddenly see just too many patients with those kinds of symptoms. And when it comes to frequency, then people need to be talking to each other. And I think one of the problems we have amongst the clinicians is that we don't really speak to each other. We all work in our different silos. The epidemic has to reach some sort of critical threshold before people realize that something odd is going on. So that's one of the challenges from the clinical perspective.
Absolutely. I want to just pick up again on the surveillance aspect of it. You all spoke about the importance of surveillance. I can speak from an antimicrobial resistance surveillance perspective, and I can tell you that there's either an underestimation or an overestimation by our passive surveillance, because generally we only send a sample to the lab when the treatment fails. So as much as surveillance is critical and it's a really early warning signal, we don't do it routinely, and there's not. With all of the different priorities on the health system, surveillance falls way down the list. So what in your professions, how would you motivate for surveillance, and how would you sort of convince the ministries of health to invest more in surveillance? What case would you make?
Well, you know, I'm just thinking you could have sentinel sites, you know, because that might be easier to deal with. But remember, sentinel sites might not be geographically located where the outbreaks are happening. So you could easily drop the ball. So you probably need to educate clinicians that if they start seeing a particular syndrome, fever, so like how it happens with flu, you come to work and then you say this person's got the flu, that person got the flu, and then there's a flu outbreak. But when it comes, but the problem is that many of these infections, which are viruses, present very much like influenza, sore throat, runny nose, they're respiratory pathogens. So it's much easier if you are dealing with an infection that kind of manifests itself in some way, some unique way. Like Ebola, for example, you got a hemorrhagic syndrome, so you would pick that up quite easily. But in terms of surveillance, you probably just need to alert the clinicians to be vigilant. I can't imagine any other way in which you could really get surveillance beefed up. The main thing might be lab, like we spoke earlier on, but from the clinical perspective, it's hard for me to think of a particular process in place as surveillance, continuously monitoring.
What about citizen science?
When you say citizen science, you mean?
Kanya, you want to take that one?
Well, I wasn't going to speak on citizen science, but I was going to add to another area of surveillance, which is now taking traction, is looking at the environment through our wastewater surveillance, because that also helps in identifying pathogens that are circulating at a subliminal level as an indicator that something is brewing in the population. So that's definitely something to consider. I don't think I can comment further on citizen science.
Okay,
but I'm assuming social media would be a great component of that.
Absolutely, absolutely. So in terms of wastewater surveillance, I'm a big proponent for wastewater surveillance. So we already have in place wastewater surveillance for polio. We also have wastewater surveillance for our normal potable water. Is the water that we're drinking of safe for us to drink? So if we can add in a few more bottles of water and look for the viruses or the bacteria, or anything, we're looking at that in the context of bacterial resistance, because it precludes invasive procedures, all of the costs of lab-based work, etc. We can do culture-based or metagenomic types of research on it. So depending upon budgets and all of that, it may be a cost-effective way of looking into it. In terms of citizen science, it's as picking up on Professor Musa's social media aspects of it. But in for example, in the UK, there was a bit about we're trying to find the next antibiotic. Give us your soil samples from exotic locations and we'll see if we can find something interesting in the soil. So it's getting the broader community engaged, not only for exciting science-based stuff, but also to say, if you see something odd or unusual, please alert the authorities. If we think about our community caregivers, they're all meant to be working in the communities and not only taking care of health issues, but also other service delivery issues. And these would be the ideal group of people to train to look into, to be vigilant about spillovers and outbreaks. Kabila, do you want to add anything to that bit?
Yes, I just wanted to add on what happens on the veterinary side. So a lot of the commercial operations do surveillance or monthly surveillance of mostly of the controlled diseases. And it's actually by law that they have to submit their numbers monthly, right? So that if there's a peak, then you can detect that there was an outbreak, or before it actually gets out of hand. But unfortunately, with the rural farmers, yes, you have your animal technicians on the ground that do go and bleed animals, but there's not enough of them to go around. So that rural surveillance is still lacking in the veterinary space. And that is one of the areas that actually does need a lot of investment, because the outbreaks don't only start in the commercial sector, they also can start in the rural, and the boundaries between rural and commercial are getting like tighter and tighter. So yeah, it's important to just invest in those rural communities as well.
Okay, so again, the equity bit comes in. Anna, you have your hand up. Please go ahead with your question.
Anna, your mic is enabled.
Anna Bastian?
Yes, sorry, I had to wait until my mic actually comes to life. I just wanted to briefly add, in terms of getting people on the ground and surveilling our animals, I just wanted to add that we have, I'm from life sciences, by the way, sorry. I just wanted to add that we have a whole group of biologists that are commonly in surveilling and sampling in wild animals, which is also something that can be used in terms of surveilling any zoonotic pathogens, for example. So that is a group of people that are in the field surveilling wild animal populations that is surely a source of information that is now just in addition bringing in populations of wild animals into the discussion. Thank you.
Wild animals have been under-researched in many areas. They not only carry, they've really been implicated in antimicrobial resistance spread in addition to other kinds of diseases. Professor Musa, you wanted to comment on that. Please go ahead.
Yeah, I was just wondering, when it comes to surveilling these different animals, is it specific pathogens that are we focusing on, or are we just doing looking for something? How do you test, and what are you testing for?
Is it a question for me, sir?
Well, yeah, Anna, you brought it up, so I thought it'd be interesting to hear your thoughts.
So I'm not working specifically on pathogens, but I am working on bats, on different aspects in the evolution and ecology of bats and population dynamics of bats. I cannot work on pathogens and hardly can do work on bats because of the limitation in terms of permits, for example, Section 20, which prevents us to do the sampling that can be used for other purposes as well, while we're doing our vast field trips, going to remote areas, sampling bat colonies. We could do this work, but in the moment we are limited in collecting samples due to those permits. So it's more about the different animal species that we're working with that should be surveyed for pathogens, for example.
I get you. Thank you.
Can I come in, Prof?
Yes, of course.
Yeah, I think just to comment on Anna's last comment with regards to the permits, because I know that when it comes to anything animals, the Section 20 permits become a bit of an issue. I think the whole concept of Section 20 is to just protect animals and the researcher. So it's not that they prevent researchers or biologists from actually going and sampling animals, but it's more of okay, can you do it? If you can do it, show us that you do it ethically, and you must have your ethical clearance. And then if you tick all the boxes, then more often than not, you do actually get your Section 20 permit. And then just to answer Prof. Musa with regards to the surveillance for the diseases, I know, for example, with what is this? Not rhinos, the other ones, buffaloes. The buffaloes, a lot of surveillance that is done is for brucellosis. And I think also, I'm not sure about TB as well. So I know that if, for example, you have a buffalo that has brucellosis, then it's worth like a cow. But if you can prove that your buffalo is free of brucellosis, then you know they're worth much more. So the surveillance is specific. But I know that with obviously poultry, it's disease specific also, depending on the controlled diseases in that area.
Thank you. Dr. Mdlalose?
Yes, thanks, Prof. I also wanted to add on the surveillance aspect, the big driver to any passage of pathogens from animals to humans are the vectors that are involved. So a huge component of surveillance is looking at the carriers. With a lot of viruses, you have those that are arthropod vectored, but you also have those that are small mammal vectored. The approach to looking at these vectors is obviously to see what type of pathogens they carry that are known, but also to then do the metagenomics approach to look at any other thing that we suspect could be responsible for disease in that population before it spills over to the human host. Thanks.
Thank you very much. So, Velile Ngidi, you've got lots of very interesting questions in the Q&A. Would you like to choose one and speak to it live? Velile, Marianne, can we activate the mic?
Okay, I
there we go.
couldn't unmute. Yeah, now I can. Choose one. Okay, it's the
Well,
behavior.
we'll let you go with one, and then we'll come back to you after we go to
Okay.
the one by Preshni. Please, you next. So please,
so
Velile, go ahead.
So it's definitely the human behavioral change, because I think it actually informs even the spillovers, plus the actual response, especially when we're talking about livestock. So I just find this, for an example, with the current FMD, I think this is lacking. And I'm just thinking, for me, with health, we know it's always at the center of our response, center of prevention, center of everything. So that was just my picture. If I had to choose one, thank you.
So thank you very much. May I just sort of probe a little bit more on there when it comes to behavioral change, and we're talking about what Gabila is speaking about in terms of rural areas, etc. My behavioral change framework is the COMB model. You have to have the capacity, the opportunity, and the motivation to be able to result in behavioral change. So when you think about behavioral change in FMD, do you think that the people involved in addressing it or mitigating it at the coalface actually have the motivation, the opportunity, and the capability? So I'm knocking it back to you. What do you think?
Yeah, sure. No, I think that for an outbreak response team, we think to be actively thinking about what the dynamics are in order for us to put together a response that is relevant contextually. And I just think if even in the outbreak response, the team combination does not factor this in, we're not even thinking about it. So for me, I think like what Mbilo was saying is that the dynamics that influence behavior, including cost implications, livelihoods and the likes, but also what are we doing to be able to support that? That's important, but also what motivates change in behavior. I just think it needs to be something we're thinking of in all sections, whether we are preventing the spillovers and the likes. I hope that makes sense. Thank you.
Absolutely. And spillovers are also as a result of deforestation and biodiversity loss. And that's because of anthropogenic activities, in addition to climate change and other aspects. So we have to think about all of these things together in the one, as trite as it sounds, One Health is really very, very important to pursue in spillovers of this nature. Preshni, would you like to ask your question live, please? Preshni Singh, the zoologist.
Hi, everyone. Thanks so much. This is a very interesting topic to talk about. Yes, so I'm a zoologist. So just like Anna was saying, we work a lot with wild animals. So I was wondering, just to pick your brains on rabies, do you think that it's more prevalent in South Africa than what we think? Because, in both domestic and wild animals, because I remember a few years ago, there were a lot of cases that were popping up in the news about rabies detected, people dying from rabies, or all of these things. So always the thought comes in my mind of like, is it more out there than what we think? And are people being more affected than what we think? And are people dying from it more than what we are actually picking up on? We might think that they'd be dying from something else. But it might be actually rabies. So I'm wondering what you all think.
So Billy, that sounds like something for you to answer, and then Eunice, I'll take it after this.
Yeah.
Okay, all of you. Okay, so go first, Billy.
Rabies, tricky one, right? But I think firstly, the Department of Agriculture is really pushing for the vaccinations of dogs, right? And it's legally binding. Like you have to vaccinate your dogs, right? But unfortunately, like I said, how many rural dogs are vaccinated? Even though the Department of Agriculture is really trying to push for these vaccinations, but how many rural dogs are actually left out unvaccinated? And unfortunately, things like the population control, You know, you can come and vaccinate those dogs, but the next month they've given birth to 10 puppies, and then those puppies will probably not be vaccinated. So maybe maybe there is a higher incidence of rabies that's not reported. And also, I think even with people dying of rabies, I think the clinical signs for rabies are quite definitive, if I can use that word. You will see someone with rabies. You will see an animal with rabies. As a clinician, as a veterinarian, you should be able to detect if someone or if an animal has rabies. But I really think that there is an element of underreporting, but the magnitude of the underreporting, unfortunately, I can't speak to it.
Dr. Miller-Lucy?
I think I would be echoing that sentiment. From our side, we get to see of rabies when there's a suspected case that needs to be diagnosed. But just from the judgment of how many of these, what we think are sporadic cases that pop up, is an indication of how much of it is really circulating in the animal population that's not adequately controlled. So to answer the question from the speaker, yes, there is definitely an element of underreporting that perpetuates the circulation of rabies, and obviously the very deathly outcome of rabies infection with humans. There's also another problem of we don't always have the control measures that are required at a time and point where infections, where animal bites happen. We've had issues where we run out of the immunoglobulins, and we've had issues where we run out of the vaccine. So those are the realities we deal with, which are other areas of strengthening the problem of rabies in this case. Thank you.
Thank you. Professor Musa? You're muted. Can you unmute, please?
Amongst humans, the disease is pretty characteristic the way it presents. You get unusual presentations like paralytic rabies that could go missed, that could be missed, but invariably the individual will die. So, and the usual presentation is the cephalic rabies, which is pretty dramatic. So I think amongst the humans, it's less likely we miss in many cases because they die and hopefully get seen by a practitioner at some point because they get very sick before they die. But I'm wondering about animals. I mean, can an animal have rabies and die without anyone knowing it has rabies, or will they invariably cause so much of trouble that you would note that the animal was sick from rabies?
It will cause trouble. It will go crazy. Yeah. So even with the cows, like cattle that get rabies, like the clinical signs are so bizarre. And so characteristics of rabies that you will see that this one has rabies. And those rabid dogs literally will be wanting to bite everyone. So you can't ignore it. And most of the time, unfortunately, in the rural settings, they end up killing the dog themselves. Because how often do you get vets coming out to like restrain the dog and take it away to be killed properly? And then obviously if they kill it themselves, then those samples will not be collected and tested, and and so yeah.
So thank you very much. We're almost about 9 minutes out. So I'm going to ask each one of you to give the audience one take-home message from each of your perspectives, and then I will conclude. So Professor Musa, would you like to go first?
Yeah, I guess it's vigilance, and especially amongst the medical practitioners is to keep an eye out for unusual presentations, and also for an increase in frequency of particular patients coming in with particular syndromes, because that may just indicate that you are dealing with an outbreak. And the idea is to talk to each other. Now with social media, it becomes less difficult because people are in groups and they'll often talk about it. But in the day, it was probably more challenging. So I guess the key word would be vigilance.
Thank you. Dr. Miller-Lucy?
Thank you. For me, it will be two things. At any given time, there is always some infection circulating in a particular area, and not always a case that if there is an infection, case in point, there's currently an issue of Nipah in Southeast Asia. the risk does not translate to us expecting a Nipah case in South Africa, even with the ease of travel. So just to make people to remain calm and not always be worried that when there is an infection in some corner of the world, it's invariably going to land in our shores. So that is the first thing. The other thing is Dr. Ngidi had made a comment on vaccine hesitancy. So the behavioral change that allows people to trust the science that informs control measures when something happens. If the control measure that's required is restriction of movement, people to trust that that information is informed by science and it is meant to help the public. If whatever information is given is to control infection, is to vaccinate, also for the people to trust the evidence that informs those control measures. So those are the two take-home messages that I would like to impart. Thanks.
And I would like to add to that, Dr. Malilo said that the health literacy aspect becomes very important there. So how to message, to give that message so it resonates with the people that we're trying to convince. Kabila, please, Dr. Pakatu.
I think from my side, it's just to reiterate the importance of, not leaving animal health systems behind, because they play quite a critical part in the zoonotic outbreaks. And so it's just us here, but, more investments really need to go into the veterinary space. If you look at the budget for the Department of Agriculture, the smallest one goes to veterinary services, right? And that's why we have now FMD outbreaks, because they stopped vaccinating for FMD. So yeah, we need to really just, we need to invest in animal health systems. I think that will assist a lot. Thank you.
Okay, so I'm going to break tradition or the agenda, and we've got Professor Richard Hift, who's put his hand up. So Richard, you have 30 seconds to ask the question, and one of you has 30 seconds to answer before I close. Please go ahead, Richard.
Thanks. This is very much just a general interest question rather than much science. No, I, like Eunice, lives in, and Sabia lives in one of the leafy suburbs of Durban. And of course, we have extensive interaction between monkeys, humans, dogs, and cats. We found it a bit surprising that there's not more zoonotic illness in Durban as a result of that, including rabies. Has anybody got a comment on that?
Can I comment? I know
Yes,
that if I know that if, for example, you get bitten by a monkey, you have to get a prophylactic vaccination of rabies. So I'm not, and even with the cats and the dogs, if you take your dog and cat to the vet, they will vaccinate it for rabies, and you say it was bitten by a monkey. So maybe that's why it's that controlled, or we haven't had a rabies outbreak. It's that vaccination. Literally, you get vaccinated every time if you get bitten by a monkey.
Okay, so thank you very much. That was a very, very, sorry, sorry, Professor Musa?
No, I just wanted to say, I think Richard's question is that, well, why don't we get more zoonotic infections from monkeys? And Richard, I suspect it's because of the intimacy of the interaction. When we see the monkey, we run, and the monkey sees us, they run away. So hopefully there's a limited amount of interaction to allow organisms to sort of cross over to humans. But if you look at China, for example, they rear their pigs. The pigs are in their household. Their birds and ducks are moving around. So I'm thinking that it is the level of the contact between the species that matters. And when you look at wild animals where there's forestation, there is some contact between the human and the wild animals, especially when they slaughter the animals and they have bushmeat. So I'm guessing that that's the reason why there's limited transmission from monkeys.
Thank you very much. So as we conclude, for me, 3 key reflections emerge. Firstly, Zoonotic spillovers are not isolated events. They are symptoms of ecological, agricultural, and socio-economic change and anthropogenic behaviors. Most high-impact cross-border outbreaks in recent decades have been viral, highlighting the importance of genomic surveillance and rapid detection. And then thirdly, the WHO Pandemic Agreement and One Health Framework provide a roadmap, but implementation at national and local levels is challenging, and that will determine the impact of the treaty. So preparedness is no longer optional. It is an investment in global stability, food security, and health equity. I want to thank our distinguished panelists from the University of KwaZulu-Natal and to all of the attendees that joined us today. Thank you for your invaluable contributions. And I will close this webinar now. Thank you.
Thank you. Bye-bye.
Thank you very much. Bye-bye.